Good morning. I'd like to welcome you to the annual Friday Satellite Symposium, sponsored by the Foundation for Women and Girls with Blood Disorders. This year, we're delighted to have a program on the global impact of anemia on women and girls. We're covering the topics of sickle cell disease, malaria, obstetric hemorrhage, and inherited bleeding disorders. If you would like CME this morning for these program, it is available, and if you have not signed up already, please see our education director, Carrie Funkhauser. This meeting was planned by our board of directors planning committee that's outlined here, and we're delighted to have as our moderator today and chair of this meeting Dr. Barbara Alving. She's an expert in hemostasis. She's a research professor at the University of Maryland School of Public Health. She's professor of medicine in the Uniformed Services University of Health Science in Bethesda. She retired from a distinguished career with the United States government, which included stints at the FDA, Walter Reed Hospital, and the NIH, where she served as acting director of the National Heart, Lung, and Blood Institute. She was director of the Women's Health Initiative, and her final tenure was at the National Center for Research Resources. These are the planning committee's disclosures. Just a word about our organization. The mission of the Foundation for Women and Girls with Blood Disorders is to ensure that all women and adolescent girls with blood disorders are correctly diagnosed and optimally treated at every life stage. And our strategy is to generate the next generation of experts in women and girls with blood disorders. These are our board members. I imagine you met some of them at breakfast, and many you'll recognize as experts in hemostasis. And our medical advisory committee includes experts from the fields of obstetrics and gynecology, hematology, emergency medicine, internal medicine, family practice, who have a special interest in women and girls with blood disorders. I'd like to refer you in the future to our website, fwgbd.org, but if you type in women and girls with blood disorders, you'll get to it easier than trying to remember our acronym. And you'll find on our website our library, our Ask the Expert feature, and our calendar of upcoming events. And right now, I'd like to turn the program over to our moderator and chair, Dr. Barbara Alving.
Thank you, Andy. This has been a delightful program in which to be involved. And I think what we're going to see throughout our speakers' talks is now an approach, an epidemiologic approach. It's time to bring some order and systematic information to the field of anemia, sickle cell disease, especially as we spread our wings globally. And as you know, although we're the American Society of Hematology, we're really the global society of hematology. But in order to really sort of determine how much do we really know about this, let's give ourselves a little bit of a assessment. It's an opportunity to assess where we're going. So what I think would be fun to do, if you've all got clickers, would to say, where is our baseline assessment? I'm going to be reading about 12 questions. You'll have opportunities to provide answers. We'll see what we think are the right answers before all of these wonderful talks occur. And then you're going to have the opportunity after each talk to retake the assessment and see if you've changed your mind about any of the information that you have. So let's get started real quickly, and then we're going to hear our first talk by Dr. Nicholas Casaubon. Question number 1 of 12. Which of these age groups have the highest prevalence of anemia? Your choice is A, B, C, or D. Begin your clickers. And the answer is several answers. So there we have it. Let's go on to the next one. Which of the following is the most common cause of anemia globally? Chronic kidney disease, malaria, inherited blood disorders, or iron deficiency anemia? Please start your clickers. Okay, looks like we're very interested in iron deficiency anemia. This is excellent. Number 3, which of the following is true when considering how to treat an anemic child? It's probably iron deficiency, so nutritional supplementation should be given. Low hemoglobin is normal for kids, no need to treat. Probably iron deficiency from blood loss, so the child should undergo extensive testing to determine the cause. Or treatment considerations should be guided by the epidemiology of underlying causes of anemia in that country. Please start your responses. Okay, let's move on. Which is true of contraceptive methods for women with sickle cell disease? Combined oral contraceptive is associated with increased risk of venous thromboembolism. Injected progestin contraceptives are not recommended. Barrier methods should be avoided, or levonorgestrel should intrauterine system is acceptable. Okay, let's move on. Which is true of hydroxyurea therapy in women with sickle cell disease? It's not recommended for women of childbearing age. Women who wish to become pregnant are advised to stop the drug for 2 to 3 months before planned pregnancy. That's an interesting response. I think 70% of pregnancies, at least in this country, are unplanned. But anyway, moving right along, hydroxyurea therapy reduces the effectiveness of oral contraceptive methods, or termination of pregnancy should be offered to women with sickle cell disease in the event of accidental exposure to hydrea in early pregnancy. Determine your response. Okay. All right, so we've got a lot of planned pregnancy. This is excellent. Okay. How many pregnant women worldwide are at risk of malaria infection in 2014? You can read the numbers yourselves. Okay. What are the main strategies to combat malaria during pregnancy? Case managements, vector control prevention using available methods such as insecticide-treated nets, use of sulfadoxine pyrimethamine as intermittent treatment, or all of the above. Okay. Current use of malaria interventions during pregnancy in African women is high, with more than 60% of pregnant women using vector control and drug treatment, moderate, low, with about 20 to 25% of pregnant women using some form of prevention, or very low, with fewer than 5% of pregnant women using some form of prevention and or treatment. Okay. The situation for global and national policies for malaria prevention in pregnancy is best characterized as incomplete global policy for malaria prevention, but with lots of hope for the next 5 years, comprehensive global policy that addresses all aspects of prevention and treatment, or comprehensive global policy, but few countries have adopted it, or a comprehensive global policy for Plasmodium vivax, but not for Plasmodium falciparum malaria, and only countries with P. vivax have adopted this policy. So this is a lecture we're really going to have to listen to, this part of the lecture. Okay. What is the leading cause of postpartum hemorrhage? Placental abruption, placental accretia, retrained placenta, genital tract lacerations, von Willebrand's, uterine atony. Oh, we're going to have to listen to this lecture too. Okay. Which laboratory test is most predictive of severe postpartum hemorrhage? Your ProTime, platelet count, fibrinogen, D-dimer, or APTT? Another lecture we have to listen to. Next. The most common presenting symptoms for individuals with rare bleeding disorders are muscle and joint bleeds, skin and mucous membrane bleeding, intracranial bleeding, all of the above. Okay, we need this lecture as well. I think it's good we're all here today. Keep going. Recombinant or plasma-derived products can be used to treat all of the following disorders except factor 7 deficiency, factor 5, factor 10, factor 13. Okay. Okay. A woman with congenital fibrinogen deficiency during pregnancy can present with bleeding symptoms, thrombotic event, peri-partum, maybe asymptomatic, all of the above or none of the above. Okay. Let's move right along. Okay.